laryngology and take care of voice patients, and that's how I know Eva. And Robert Andrews is also one of my practice partners. He's going to speak next week, and we kind of got out of turn a little bit, but we did try to get in sync a bit because there's a plethora of knowledge, a plethora of information. I don't want to inundate you with it, but it's pretty cool and about how your instrument works, and it's pretty amazing, actually. It's the most complicated. If you ask me, it's the coolest tissue in the human body. It gets beat up more than anything else that we have. It moves faster, it takes a beating, and it moves our entire life. It's been moving since before you were born, and it'll keep moving till you quit breathing. So it doesn't get any credit for how cool it is. So I was going to talk about lumps and bumps and nomenclature, which, you know, I'm a stringent, rule abider about nomenclature, but I think if we aren't, we can't speak the same language to have really accurate diagnosis. So, and then Dr. Andrews is going to talk more about sort of physiology, how we evaluate things, how we can see what's going on in there. So I didn't really include much video because I didn't want the cart ahead of the horse. So he's going to talk more about that stuff next week. So I'll just gloss over some anatomy and physiology because it makes sense of how you can get into trouble. And then parameters to assess with nomenclature that accompanies, and then some of the good, the bad, and the ugly, some of those lumps and bumps. So video stroboscopy is this imaging modality we use with a scope to see how your vocal cords vibrate. They vibrate so fast a human retina can't see that many images a second. We can only usually process about 4 images a second. So the strobe light fires at random and gets pictures of how the tissue's moving. And so it's actually factitiously recreating that so that we can see it, slow it down. But at my speaking pitch, my vocal cords oscillate, or vocal folds, synonymous terms, 200 hertz, 200 times a second. When you guys are wailing on some of those high notes, you're 800, 900 hertz, okay? Freddie Mercury, actually, it's very cool because posthumously even, he's been, voice scientists have analyzed like a full legit 4-octave range, goes up to almost 800 hertz. That tissue's moving. So it's pretty cool, and no wonder it gets beat up sometimes. So it's really amazing when I see, or just hear you guys do that sort of stuff, I'm like, that's a physiologic marvel to me of how you learn to do that. And that's a whole other discussion because with you guys, when you're able to do that, they're really elite, like tenors, or they're elite, like at least some of these things have been looked at from functional MRI, as well as some of these super smart voice scientists look at the physics of the acoustics. These people can do crazy stuff. It's cool. Like they can dilate, they contract their spine backward. I geek out on that. I think that's cool. They make their pharynx bigger because they actually pull their spine backward. They do all these really cool things with their palate, but it's really neat. So,
that's the back space. Okay.
They're pulling their spine backward. Like, how do you even do that? But they learn with all their training. So anyway, with stroboscopy, what we're doing is we visualize how the vocal folds oscillate, and we can use it 2 different ways. Either we go through your mouth with this thing that looks like a periscope, or thing through your nose. And then why we do it is, it's a more advanced analysis for looking at how this tissue moves, okay? Because otherwise you can't see it at all with plain light laryngoscopy. So if you go see an ENT who just uses a plain scope and doesn't look at this, they're likely not going to give you a really accurate diagnosis. There's a lot of things you can pick up with plain light laryngoscopy, but there's a lot of stuff you'll miss. And then it's usually someone like me or Eva who actually does this sort of stuff.
The laryngoscopy's down the throat.
Yes, ma'am. So we either look through your mouth with an angled telescope that's like a periscope from like a submarine. So we look at that. So the submarine, you go up and over the water, we go back and over the back of the tongue, or we can go through your nose. And there's a variety of reasons why you use either one. They're complementary exams. One's more of a neurologic exam. So if I'm having you go through your mouth, I can't tell how well you can actually control all those muscles. So there's reasons to do one versus the other. Like if it's a singer with just a pure lump or bump, the best way are some of these pretty pictures I'm going to show you is through the mouth. Okay. So anatomy of vocal folds. So this is so silly the way we do it this way. And I'm sorry if I'm in your way. But we look through the mouth. So ENTs for about 150 years have been trained to look at the larynx through the mouth with a mirror. Okay, so that's why with a digital camera in 2019, we still flip this sucker upside down and backwards. It doesn't make any sense why, but that's why we do it. So this is your right vocal fold or vocal cord. This is the left one. They close for basically everything you do in your life except take a breath in. So you open them to breathe and you close them when you laugh, talk, cough, swallow, sing, even have a bowel movement or pick up something heavy. You can't do any of those things without moving your vocal cords. They don't get all the credit. Cool. So this is, if you look and see this bright white area in the back of the vocal fold, that's where the cartilage of the arytenoid cartilage, this thing that's sticking straight up, is actually this big pyramid-shaped cartilage, and all the muscles that basically control your vocal cords attached, basically most of them attached to that cartilage. So the vibratory portion of your vocal cord is from there to the front. To put that in perspective for we women, it's not even barely a centimeter. It's really small. It's highly magnified. Okay. In a kid, well, to put this in perspective, your trachea is the diameter of your index finger. So that's how big mine is. That's how big yours is. So it's all really pretty small. So a baby is, similar. So all that stuff you do to be able to talk and sing happens here. But really, the most important functions of your larynx is to breathe, right? Because we can't survive without it. And then really to swallow. And then to be able to expel mucus, cough, protect your airway, not die from pneumonia. And then the last thing phylogenetically is to produce a voice. And so it's more of us as a higher order primate to be able to do that. And then we as women, this is a woman, I can tell by looking, because we have a physiologic gap. We keep a gap in the back of our larynx when we close our vocal cords or vocal folds. Men don't. Children keep one, and then once a boy is peripubertal, then a male vocal closure pattern is complete.
Is there a scientific reason for that?
We don't know. But I can tell by looking what's normal, what's not. So it's a pathologic gap if it's bigger, Because the reason this matters is really voice production or be able to have a normal voice depends on normal mucosal wave propagation and vocal fold closure. That's it. It can boil all the way down to that. Now all these parameters we look at dice that up into a lot of complex little things, but you need to have normal vibratory function and to have normal closure pattern. And I'll explain why. So here's a cartoon of the microstructure. So this is like we slice the human like this. Okay, so this is called the coronal plate. So we slice the larynx like this, and this is a cartoon. The vocal cord or vocal fold, and that picture looks like a white stripe in space, but it's actually this three-dimensional curvilinear cool thing that's about 1 centimeter deep, and it has some curved structure to it. And so when you see it on side view, it looks like this. And so airflow comes up from your generator of your lungs, initiates this tissue to start moving under your vocal cords, and then it undulates in this very cool and complex 3D wave from bottom up and front back. And it oscillates that fast, so 200 hertz like I'm talking right now, and it's doing that constantly, all the time. So what's nifty is that this is the adult, so by the time we're about 13 years old, this is what our larynx is like with our vocal folds. It's a 5-layered microstructure. It's this very elegant, layered, multiple viscosity, so basically like different layers of jelly. And it vibrates all with different rheologic and vibratory properties. And they have to be this way for our voice to be the way it is. So it's really pretty nifty. So there's muscle, and then there are 3 layers of what's called lamina propria, and that's that gelatin stuff. And it's all different viscosity, and it's all layered. So when we're an infant, we're born with this monolayer. It's just this blob of jelly. That's why it's pretty nifty. Think about it. A baby can scream for 3 hours and they don't get hoarse most of the time. If I knew the magic juju that was in that little kid, I could help other patients, right? Because you can fix what goes wrong. But then as we age from infancy up to 13, we turn into this. This matters because of lesions. So this is the epithelium is the cover. There's this basement membrane zone of how that cover adheres to then the superficial lamina propria, and then the intermediate, the deep, and then there's vocalis muscle. So
we have these tiny little things, and then they have those layers. Because I think I always forget. I always want to think it's just the 2, but it's actually this multi-membrane.
Oh, very much so. And it's and so I see creatures big and small with voice issues, and so for me with children, it's a moving target. And I geek out on this stuff because a lot of this stuff with kids is really poorly elucidated, but I feel like I do a better job with adults because I can understand the little folk, and I can bring airway tricks from little people to big people. So that's why I did what I did. So if you read my bio, I'm like, why is this pediatric person coming to talk to us? But I did both. So we're on nomenclature. I really am stringent about this because if we don't speak the same language, we're not going to offer you appropriate treatment. Okay? you know, a lump, a nodule, a node, whatever you call it du jour these days, is a different thing to different people unless you really are distilled down to a really accurate diagnosis and stringent nomenclature, because certain of these bumps are going to get better with voice therapy, and some of them are never going to get better. Some of them might get worse. You want to have an accurate prescription of voice therapy so you don't waste your time, effort, money, etc., going through all this stuff not to get better. And sometimes the dreaded surgery is what you need from the get-go. Or I can say, you know what? Those suckers are going to get so much better with voice therapy. You're going to get better, and you know, you have at least accurate expectations as well. So there's ways we describe these, and I just have a litany of adjectives, but we describe, you know, how soft it is, how firm, round, is it fluid-filled, is it large, is it small, you know, what color is it patchy, is it irregular, is it, you know, causing vibratory perturbation, there's a whole, you know, secretions stick to it, there's a whole bunch of things we look at. And we're doing this in like a, you know, 90-second video, but we look through a litany of things. And then also how well it closes. And then are you working too hard when you're trying to voice, because you're overcoming a litany of problems. So, and then not to also make your head spin, but there's a variety of things that these are the common things, and it's just a list of them. So these are the ones I was going to talk about. Spinal-traumatic lesions can be caused from, you know, singing sick, lots of puking, lots of coughing, yelling it up at the Super Bowl party too much. Then there's also vibratory things such as scar or sulcus vocalis is a really uncommon thing where you basically are missing some vibratory tissue. You know, vocal fold scar, you know, sometimes people like it. So Peter Gabriel sounded cool in the 90s. You know, he got scarred. He sounds great. You get a kind of a more raspy quality. Or Steven Tyler. He can only nail some of those high notes because it's a solid sheet of scar. I don't even know how he's doing it, but
that's fantastic to know, because I actually have some pop singers, like students, who I have some metal singers, and then I also have the pop, and they want that rasp, and I'm like, did you realize it's vocal damage, right?
A lot of times it is, and then sometimes it's wear and tear over life. But sometimes people like it, you know. So, and then there's a bunch of other things with like whether or not they move appropriately, how you're aging, if you've got tumors or scar or different other things. But this goes back to the same picture I showed you. This is a histology slide. So this is the actual human vocal fold stain, and lesions tend to pop up. Either superficial ones will pop up here just beneath the epithelium. So I'll show you the epithelium basement membrane. This is right here in the superficial limb appropriate. Or these are more nasty ones. These are down by vocal ligament, right on top of where that deep layer of the superficial limb appropriate adheres down to the vocal ligament and that vocalis muscle. And you know, you want to figure out where they are even before, you know, because you want to give an accurate diagnosis. You help patients with voice therapy or how to rehab through it, or whether they need surgery. And if they need surgery, you can have a real talking to, okay, this thing's in the ligament, I need longer voice rest. And I guess I could really bore you for a long time, but we've really shortened voice rest. There's been some really cool science where it's this one time where all that funding for a lab actually helped patients. About 6-7 years ago, some really cool data came out that voice rest more than 3 days is probably unnecessary. Because if you look at, it's in a bunny, a rabbit model, but the vocal cord, that incision we make to remove a bump, readheses at about 72 hours, and all the chemicals in the tissue also normalize back almost to normal, the inflammatory markers. So we don't have to torture you with, like, no one should ever put you on 2 weeks of voice rest, run away screaming and call Eva or me. Like, there's no reason anyone in their life, like, I want a physician moms group, and people will post this stuff, I'm like, no. There's no reason a human being should ever be put on that kind of voice rest.
Now, one more question. When you say the word lesion, that's not the same as nodule or polyp.
Sorry, generic term, so lesion means anything.
Okay.
So lesion can be a tumor, it can be
Any imperfection that shouldn't be there.
correct, and anything that you know that shouldn't be there, exactly. And I don't ever mean to be stuck in jargon, so stop me. And I don't mean to dumb it down either, so I never mean to get stuck in nomenclature. But this really matters about where you believe it is, and you can tell because deeper lesions or bumps or cysts or whatever will cause much more substantial abnormal vibration, whereas more superficial things don't. So nodules, okay, are rare. I have a beef with this. I think I even give a talk like, you know, lumps and bumps, it's not just nodules and knots in all red and capitals, because things get blamed as nodules, but I think most of those were probably something else if you got a better look. But by definition, I mean, you can barely see these things, okay? If I point it out, there's a tiny bump and a tiny bump there, okay? Lesions that are this superficial don't disrupt mucosal wave, and that's the definition. They need to be on both sides, they need to be symmetric, and they reverse entirely with good voice therapy. And that's why it's really important to know the difference, because you can tell the patient, hey, these little things you got, go see Eva, she's gonna make you better, you're never gonna need surgery, la 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 la, you know, and you can give people realistic expectations. But these are actually really rare, if you ask me. You just, either your doc didn't good enough look, or they're calling all bumps nodules, and that's not true. So then, they're always symmetric.
You're actually you get them on both sides. No, but like the size of them on both sides,
Right here.
even if they're next to each other.
They're perfect. This is a perfect example of textbook nodules. You see those tiny little things right there, right there?
Right. No, I get that they're beside each other. But you're saying they also the exact same size?
Pretty much, almost 100%.
So what are they, there's just one?
Oh, we'll get there. It's
What
like
is-
an infomercial.
What if they're right by each other, but they're not the same size?
Then we'll get there.
Oh.
But that's how most of them are. That's how almost all of them are.
for it.
So wait for it. So, but these are actual nodules. These are cute, tiny, little precious nodules. They will go away with good voice therapy. They'll reverse entirely. They don't.
Look at those cute ones.
And they don't disrupt mucosal wave, which is key, because when you really pick through of how this vibrates, that's how you can tell. Okay. Polyps, and I hope this translates. I hope you can see. This is a nice, juicy little hemorrhagic, cherry little polyp.
I had a friend in the program who had a nice polyp, and I knew something was wrong because it wasn't like you could hear it when she was singing, and I knew it wasn't breast support. There was something else going on.
You
It
can
was
hear
like
them.
a constant hiss when she was singing. It was really strange.
So you hear singers get these. I would imagine. Remember the guy who did those commercials for OxyClean? Kaboom! Billy Mays. Homegrown stops is what we call those, but it's like boom, 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 boom. And so their vocal cords slam together, or I call it the disease of the Southern minister. I've seen so many Southern ministers with these too, because that speaking technique where they, you know, they repeatedly slam their vocal cords together, and it bleeds a lot. And so this is a hemorrhagic polyp. That's not going to get better with voice therapy. Voice
Does
therapy
it spit out blood when you said it bleeds, or does it just bleed and
it's
then drip?
internally. It's all internal. So it's a blood blister that keeps re-bleeding, and then we don't know why. You know, patient A will get this, you know, thing, and you grow a cyst, and you grow a fibrous mass, and you got nodules. We really don't.
Oh, good,
know
I get
why.
nodules. Sweet.
I just picked.
Get the cute ones. Get the cute
You get the
ones.
cute ones. Yours goes away. There's your surgical. So, no, but seriously, but these are almost 100% of the time surgical. Voice therapy doesn't help them. Sometimes it makes it worse. There's certain voice therapies that will definitely make it worse, and that's where you also need to see someone who knows what they're doing. You know, like Eva, because she's not going to do, you know, voice building exercises and so on with this, because she's just going to make it bleed worse. It's going to get bigger and bigger and bigger and bigger. So this is almost always surgery. There's another type of polyp, and I wish you could see it, because this one, I wish it projected. So these things tend to be really superficial in the vocal cord. This has got some nice gelatinous, you can see it's kind of glistening. That's all filled with this, what looks fluid filled almost, but that stuff in there is almost overgrown, that superficial lamina propria, that jelly.
Oh, it's not pus.
It's this gelatinous stuff. And the epithelium overlying, it's always abnormal, but this is always superficial in the vocal fold. It does not disrupt mucosal wave. It causes a bad voice because it impairs the way you get closure, and so you get this hourglass.
And it's only on the one side.
It is on the one side. You can get them bilateral. It's a real rare. They're rare.
But you want the nodule.
Well, polyp, if you had to get surgery, it's the easiest.
So what do you call this?
This is a little polyp as well. They're just different types of polyp. And this is a honker of a polyp.
Ah.
That's a trick surgery.
I don't even know what that is.
So this is these are the vocal cords at surgery. So it's flipped back upside down. So this is left vocal cord. This is the right one. This is surgery. So we've got this instrument's right in the legs. It's highly magnified. So this little bump is still only like a millimeter or two in size. It just looks monstrous, but that's a good juicy polyp. So you can see it's filled with this gelatinous stuff. And all the epithelium over the top of it, the cover, is all abnormal. So you remove these usually by it's a very superficial dissection. These patients go on 3 days of waist rest. They do great. They do wonderfully.
I'm getting a sore throat just looking at these.
Well, those patients do. I mean, a lot of these people do a lot of pain. You get a lot of neck pain. You're sore. You have ear pain because you contract all this stuff, all these muscles in your neck abnormally, and they all innervate with some nerves in your ear. And so there's a bunch of, you can have all kinds of symptoms. And that person right there is probably ferociously hoarse.
I saw a scoping of Professor who had actually had a stroke, and so the other one was taking
So it
over
was,
for
so
the
it
other
was,
one.
I didn't put any paralysis or anything.
Oh, it's fascinating though.
Mhm.
But it was huge. It was like this big, and then the other one was like
It looks weird, yeah.
It's crazy.
And that's cool to fix. That's like my favorite thing to do. So, sorry.
He puts the shot. Is it Botox they put in it to fill it up?
We put different, so we shoplift stuff for people and their wrinkles. So we know that fillers are safe, and there's a bunch that are on the shelf, and so we borrow stuff for plastic surgery and stick in your vocal cord. We don't have an implant that vibrates like your natural vocal cord. The best thing we have is human fat. It vibrates really well. It's just precarious to transplant it. It's one of my, I'll do it, but unfortunately in America, we tend to have an abundance of it. A lot of I just had 2 babies last year. I'm more lumpy than I'd like to be. But yeah, so there's a lot of things, or there's other ways to permanently rearrange that so that you can give them a normal voice for years and years. That's probably my favorite thing I do. This is a cyst, and so I would stress that this one's subepithelial because it's under the cover of the vocal cord. It's round. Okay, when you actually watch this on stroboscopy, it disrupts mucosal wave. And the reason, I didn't want to go through this first, that's probably why you were asking this, or part of it. You tend to get bumps in the exact same place in the vocal cord because it's the point of maximum stress and maximum impact. I told you this vibrates really fast all the time. There's maximum force, friction forces. It's always this mid-membranous right here, the very center of that. So I told you that's cartilage from the back, from see about there to the front. It's the very middle, and that's where the maximum friction and maximum impact forces are with vibration. So this is a cute little cyst, and see there's a bump on the other side. We always almost get one on the other side. It's just not the same.
On the cyst.
So there's a cyst on one side, so this is your cyst, and then we call this a reactive or a companion lesion, but I have a slide about it later. I probably should have put it forward. They have a friend. It's a companion. Lesion and companion, so it's like a haiku or something. So anyway, this one's not so deep in the vocal fold. This is another one, and I have this one because I have a picture of it at surgery taking it out. But this one's also more broad-based, or at least it looks that way with a highly magnified picture, but this is an OR shot. And it's under the surface, and if you watch this, it does disrupt vibration. And then, I'm sure you wish you could see it. There's
mucus, or is
the
that
cyst popped. They almost always pop, unless you're really, really good at getting them out. They're tough to take out. But that's the cyst wall.
Vocal pimples.
And so, yeah, they do pop. A lot of these things pop. And so, but yeah, that's a picture of taking it out. And so what you do is you make a little incision along the free edge of the vocal cord. You lift the cover up. You protect all that superficial lamina propria, and then you carefully get this little cyst out and leave all that normal stuff behind. And that's not where I'm tooting my horn, I'm gonna toot my horn. That's why you need to see someone like me or Dr. Andrews or folks at the Airway Voice Center. There's not that many of us who do this, and when the stakes are high. And truthfully, I think the stakes are high for everybody. You know, we're all voice users. I couldn't do my job if I couldn't talk. Vocational voice users are teachers and clergy and judges and singing teachers and singers, you know, the rest, all of us really. This is another one, but it's just a nice bigger one. It's another nice round cyst. And then a companion bump on the other side. And then these are the biggest things I've ever seen. These are the best juicy cysts I've ever seen. These are like world records. I can't take credit for this. Mark Corey this was back when he was at Vanderbilt. I don't know if you can make these things out because this is really outdated, old imaging equipment, but look at those things. They're amazing. It's like an Easter egg in both vocal cords. It's awesome. I promise you that person's ferociously hoarse. I mean, they're usually really, 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 really ferociously
forced to hang.
And I didn't bring any of my pediatric because I figured that might not appeal to this crowd. You know, I've got a bunch of video or pictures of kids. There's one little boy I took care of about 9 years ago. Comes in and gets tonsils like because he's snoring. And he starts talking to me. I look at his mom. I'm like, does he always sound like this? What do you mean? That's him. I'm like, and he's talking to me about like that. I'm like, well, Mom, that's what he sounds like. I'm like, let me scope him, let me show you. And he didn't have him quite like that, but he had the kid version. And it was pretty awesome. So, and you get those out and you make their life different. You know, it changes them. It changes their personality because he got really shy, didn't want to talk to people because he got sick of repeating himself. So anyway, those are just awesome ones.
Do you think it was a behavior that caused that? Or?
You know, I bet in a kid, that kind of stuff might have been congenital.
Because I had one who, I can telling your mom, because I know kids get diagnosed with acid reflux more now, that she's like, no, he's just always been this way.
Well,
it wasn't quite as bad as you when I said.
So if it was that, then it was probably a different type of bump.
Okay.
If it's a cyst, it's pretty bad. They sound horrible.
Okay.
But there's other things, such as fibrous masses. This is like an infomercial. This is all just.
Which one are you selling us today?
Yeah, nobody gets surgery today. I don't think. I don't hear anybody.
QVC of.
Yeah. So,
selling us
these are. This one is ligamentous, and I have this out of order because this is the deepest one. But you can almost make out this thing that's further over. You see that bump right there? Where
It's
I
like not
outlined
on
it?
the inside.
Mhm, it's more over, and you see it deeper. So you see it when you're taking this picture, you're watching it pop up. That's why we watch it dynamically vibrate, because these things move. And so with different tasks, you can make these suckers pop out with different pitches and different tasks. But I think most people miss, because look, if you really didn't look, and if I hadn't told you this, you can almost think that that was similar to some of those nodules. And I think a lot of what gets labeled as nodules were actually little smaller fibrous masses. And why that matters is fibrous masses, when you open them up, they're this sort of just amalgous, it's not gelatinous stuff, it's denser, it's not quite scar, but if you look at it microscopically, it's full of scar-looking changes. They're a little trickier to get out if they're really deep, but they're similar to like a cyst. A lot of these need surgery, a lot of them don't. A lot of people learn to function around these, and the caveat I tell you is that with voice therapy, most cysts, unless they're really small, most people need surgery. And sometimes we send you to voice therapy pre-op because we want you, it's almost like doing pre-op PT for your knee replacement. You learn some muscle memory and you kind of get an idea of what you're up against, because you tend to rehab faster after surgery when you've done it that way, even though we have no expectation of you ever getting better. But a lot of these will get better. And they might not be completely normal, but what I care about is if you have limitations. And if you're unlimited, I'm fine, right? If you can do what you want to do and you can, your range, because usually what happens when people have these kind of bumps, they usually have, so when you go from, you guys are classical and do everything, or, yeah, so people go to, the head voice, chest voice, where those transitions are, those passagios get big. People have a blunted upper register.
There's like a big vocal break.
There's a huge break, and women have 2 physiologic breaks. So when we go from our very lowest all the way up, we have 2 physiologic breaks. So it's not just chest and head voice, but a lot of MT and Broadway or different genres call it that. But we have 2. But those get big. They get really wide. People who struggle with transitions, their upper register gets shortened. They can't hit those high notes because when they really are trying to, those suckers contact prematurely, and you can't control how the rest of the vocal cord vibrates. So you're literally trying to like surf on a high wire. I mean, it's super difficult to do. And high soft notes are super difficult. And then reactive lesions. So the reason you get a bump on the other side is I told you this sucker vibrates so fast. So this firm, say cyst right here, vibrating on the opposite side causes almost like a callus. Sometimes I have to take those out. I can only tell at surgery if they're firm or whatnot, but most of the time you take the offending guy out and the other thing goes away. Okay, but it's usually if someone says they've got nodules and they show you a picture like this and they're different, they're not nodules. And so your expectation for them to like melt away with voice therapy, it may not be realistic. And so that's why I'm so stringent about nomenclature, because if you don't get the accurate diagnosis from the beginning and also have really stringent verbiage, I'm not doing you a favor. I'm not a good colleague to our speech pathologist. I'm not really choosing appropriate treatment. I just feel like it all falls apart. And there's another one. So this is another little polyp. That's a red, juicy, I use the grossest word, sorry. When I'm talking about nasal, something like, so is it creamy? Is it slimy? Chunky? Sorry. Yeah. But this is another hemorrhagic one. So these things repeatedly bleed, and then you get a little reactive bump. See that little guy on the other side? And usually that goes away once you just take the dominant lesion or bump off. Now this is a really perfect one, because if you watch this in vibration, it looks like a cup and saucer. Okay, and this is a perfect still image when you go frame by frame and we catch a picture like this, because you see the dominant, and that actually looks like a watery little polyp. It's a bit broad-based, and there is this cup and saucer. So that's your lesion, and that thing with the indentation is your reactive lesion. It's kind of neat though how they will look that way. And it's important to figure it out because you don't want to be going, you don't want, all the world's a nail, I've got a hammer, I'm going to operate on everything. Like usually you don't have to take those off. And then there's a whole spectrum of other stuff. You can be born with webbing, you can acquire these weird webs from, surgical injuries, airway burns. You can have some benign tumors. There is congenital stuff. Little kids can be born with these benign blood vessel tumors. You can have some post-surgical changes if you've had airway injuries or laryngeal trauma or crush injury, fracture your larynx, all kinds of horrible things that can happen to us. Aging is, I know it's like a horror movie, sorry. I'm coming in with worst case scenario to like singers. Atrophy is really just how we age, and what's so cool is that you singers, if you sing forever, what I usually see is a lot of you really do well for the long term. The more, think what Tony Bennett doesn't sound like he did. He got a record in his late 90s, because he kept it going. The more you use it, usually the better they are. Rinke's edema is the medical word for smokers' polyps. You get all kinds of weird fungal and yeast infections, and then there's all the reflux stuff. There's a whole litany of controversy about what you can get from reflux or what not, and I think it's not the reflux itself, it's what you do from the reflux. It's all the coughing is what I usually think is what usually tears you to pieces. But really elite performers will have increased effort from reflux. Like they'll notice it differently. And then granuloma is another type of benign mass that's either from coughing or reflux. You can hemorrhage and get all kinds of badness from that before you grow a bump or a polyp. And other benign tumors, et cetera, et cetera. So really, detailed exam is key. You really have to be very descriptive so that you're accurate, and it allows for a correct speech pathology treatment plan. It lets your singing coach know what their limitations are, how far to take you, when to stop, when to restart, all that stuff. And realistic expectations on when surgery is really needed. So that was it. I'm sorry our projector didn't work.